Hello, welcome back to the Didactics. On today's lecture, we are going to look at the approach to hypernatremia. So let's start. So the concentration of sodium in our plasma is the ratio between serum sodium and water in the extracellular fluid. We call it hypernatremia when the serum sodium level is more than 145 milliequivalents per liter. The basic pathophysiology behind hypernatremia is that the body loses free water. And it can also rarely happen due to high levels of sodium, which is very rare, but seen typically in situations where we are treating a patient with hypertonic saline and we are giving overzealous correction, and that is leading to high body sodium and subsequent hypernatremia. But this is rare. Mostly, we lose free water either through urine or GI tract or through sweating or someone if is not taking enough water. Now let's talk about the water distribution in our body. Water always exists in osmotic equilibrium in all the compartments of our body. The right hand chart is showing us the intracellular compartment and the extracellular compartment. Water distribution in the extracellular compartment is 33% or 1/3 of total body water, and the rest 2/3 is distributed in the intracellular compartment. In the extracellular compartment, 25% is only in the intravascular space and 75% is present in the interstitial space. Now, if we consider water loss, it affects all body compartments in proportions. Keeping that in mind and following the previous charts, we can say if we lose like 1 liter of water from our body, it will be only 80 ml that gets lost from our plasma. So that would be pretty much hemodynamically insignificant. So pure water loss minimally impacts plasma volume or hemodynamics until the late stages. With all this in mind, let's start with the causes of hypernatremia. As we already discussed, the causes of hypernatremia can depend on water loss, reduced water intake, or sodium loading. Increased water loss can be seen through genitourinary tract, gastrointestinal tracts, skin, respiratory system, and common examples are diabetes insipidus, osmotic diuresis, severe diarrhea, fever, burns, and hyperventilation. Decreased water intake secondary to altered ventilation, or if the patient is on ventilation and dependent on us medical professionals to get the water, can also lead to hypernatremia. Sodium loading is a rare cause of hypernatremia, and it is mostly seen in iatrogenic conditions or Conn syndrome. It is most of the time it is associated with hypervolemia as well. Another important thing when determining the cause of hypernatremia we have to keep in mind is that we have to think about this sodium balance. Sodium balance can be negative, normal, or positive. Negative sodium balance is seen when the body is losing hypotonic fluid. It is typically associated with clinical signs of tachycardia and orthostatic hypotension. Normal sodium balance we see when the body reserves the sodium but is losing the water. Loss of electrolyte free fluid. Patients are euvolemic but total body water is depleted. Causes include renal losses or extrarenal losses. Renal losses are diabetes insipidus. And extrarenal losses can be due to increased insensible loss, decreased intake, or intracellular shift. Positive sodium balance is least common type and often associated with iatrogenic administration of sodium bicarbonate, hypertonic saline, and normal saline, or it can be due to mineralocorticoid excess or Conn syndrome. Now, with this in mind, let's come to the diagnostic tools that we have. We can check serum sodium every 4 to 6 hours while treating and correcting the hypernatremia. We also have to assess the volume status and body weight to go for the proper management of the patient. We also have to measure urine output each hourly, and urine osmolality and urinary sodium and potassium is also mandatory to check. Now let's talk about some clinical aspects of hypernatremia. So the most important question, who are commonly affected? Patients are affected due to some sort of lack of access to water or increased loss of water. The lack of access or increased loss can be seen due to altered mentation, can be due to inadequate, inappropriate fluid prescription by us. Patients are intubated or critically ill, and elderly patients with some sort of infection that is causing delirium and reducing their sense of drinking water. The common symptoms from hypernatremia is typically neurological. It can cause altered mental status, fatigue, lethargy, irritability, confusion, seizures, coma. See, in severe cases, due to loss of brain volume, we can also see tearing of the cerebral veins, and that can lead to intracerebral and subarachnoid hemorrhage. But we typically see that in infants. If the patient has diabetes insipidus, we can expect polyuria or polydipsia. Common signs from hypernatremia, we can see our abnormal skin turgor, which is tested by skin pinch test. If the skin does not return by 3 seconds, we can assume that the patient is hypovolemic, and altered sensorium is also present. And for hypervolemic hypernatremia, we can see signs of volume overload such as elevated JVP, edema, and we see that mostly after getting 3% NaCl infusion. Now let's come to the management aspect of hypernatremia. The first thing that we are going to do is to obtain a thorough history, and we will perform a physical exam to assess the volume status of the patient. The next thing that we are going to do is correct the sodium depletion with normal saline if the patient is hemodynamically unstable, because the patient requires resuscitation. We need to resuscitate before correcting the hypernatremia. After getting the history, physical exam, volume status, we can calculate the free water deficit. Total body water is 50% of lean body weight in women and 60% in men. The formula to calculate the water deficit is total body water multiplied by plasma sodium minus 140, or the target sodium level after 24 hours divided by 140, or the target sodium level at 24 hours. Now we will determine the replacement fluid. For pure water loss or euvolemic hypernatremia, we can use enteral free water via oral or nasogastric tube, or IV 5% dextrose in water. For hypotonic fluid loss, we can use 0.2% or 0.45% or half normal saline, or separate IV solutions for water and salt repletion with 0.9% saline. After determination of the replacement fluid, we can think about the route. Enteral route is preferred over IV route. IV route is common initially, especially with altered mental status or if the patient cannot drink the water safely. Now let's come to the most important part of management of hypernatremia, the rate of repletion. We will try to correct the serum sodium at the rate of 0.5 milliequivalent per liter per hour, or 10 to 12 milliequivalents per liter in 24 hours. Acutely symptomatic patients may require initial correction of 1 to 2 milliequivalent per hour. One thing we should note that the rate of 0.5 milliequivalent per liter is not backed by any human studies yet, but it is a safe rate to correct the hypernatremia. And if we go beyond this rate, it is only harmful for infants, not in adults. Now, the next part of management of hypernatremia is that we have to determine the ongoing losses. And we can divide the losses in two parts, sensible losses and insensible losses. The sensible losses, we have formulas to calculate. We can measure the electrolyte free clearance in our urine. So the V is the urinary volume multiplied by 1 minus urinary sodium plus urinary potassium divided by plasma sodium. And we measure the insensible losses by these specific rules: 10 to 15 ml per kg per day for women and 15 to 20 ml per kg per day for men. The insensible losses can increase in situations like burn, fever, hyperventilation. We can also measure the urine osmolality in non-oliguric patients. If urinary osmolality is less than 250 milliosmoles per kilogram, it indicates towards diabetes insipidus because we are losing more of water. And if urine osmolality is more than 300 milliosmoles per kg in non-oliguric patient, it indicates towards osmotic diuresis. Even after calculating all the equations and everything, we always have to measure serum sodium every 4 to 6 hours to look for over or under correction. And we also have to keep in mind that if we do not treat the underlying condition, then the hypernatremia is not treatable with fluids only. So if there is central diabetes insipidus, we have to give vasopressin agonist like desmopressin. For nephrogenic diabetes insipidus, we have to give thiazide diuretics, low protein, low sodium diets. For positive sodium balance, we correct the hypervolemia with diuretics and replenish the free water deficit. Now, with all these ammunitions, let's discuss about a hypothetical scenario. A 50-year-old male with ischemic CVA in the ICU is unresponsive. He was found in the subtender states by his neighbors. Serum sodium is 165 milliequivalents per liter. Urine output is 150 ml per hour. Body weight is 70. Blood pressure is 120 over 60. Now let's manage the hypernatremia. So from the history, we can see that the patient is suffering from cerebrovascular accident, which can cause reduced water intake. Or we can also think about CVA-induced diabetes insipidus. And I'm also assuming that the onset of hypernatremia is indeterminate. So the proper correction rate would be 0.5 milliequivalent per liter per hour or 10 to 12 milliequivalent per liter per day. Next, we'll start with our physical exam. I have already seen that the patient is maintaining the blood pressure and the patient has normal skin turgor. So we do not need 0.9% saline to resuscitate the patient. The next step is to look for the water deficit. So to calculate the water deficit, we multiply the body weight with 0.6 in male patients, and his current sodium level is 165 minus 155. That is my target sodium level after 24 hours divided by 155. That gives us 2.70 liters per day. And if we convert it in hourly rate, we get 112.5 ml per hour. As this free water deficit equation is a static measure and it does not include ongoing losses, we have to measure the ongoing losses. So the sensible and insensible losses. The sensible losses are electrolyte free clearance, which is V volume of urine multiplied by 1 minus urinary sodium plus urinary potassium by plasma sodium. So 150 ml per hour urine output the patient is producing. So 150 multiplied by 1 minus 25 plus 15, both of which are hypothetical values for urinary sodium and urinary potassium, divided by 165, which is plasma sodium level. This gives us 114 ml per hour, which is electrolyte free clearance. We need to add this to the fluid that we are going to give the patient. And for insensible loss, we multiply 70, which is the body weight of the patient, with 15 ml per day. So that gives us 1050 ml per day. And if we convert that to hourly rate, it would be like 43.75 ml per hour. So we add this whole thing to the replacement fluid. That gives us the total replacement fluid of 270.25 ml per hour. Now the choice of fluid is D5W as the patient is euvolemic clinically. And the route of administration, I would prefer IV first, as the patient is obtunded and probably intubated as well. So I'll prefer IV over oral correction. And if hypernatremia improves or the patient's mentation improves, then I would also prefer the oral correction of hypernatremia. Now, next thing that for this specific patient I'd love to check the urine osmolality and copeptin level, which is C-terminal peptide of vasopressin. So if we get like urine osmolality of 240, which is low, and absent copeptine, we can probably diagnose the patient with a central diabetes insipidus, and we can assume that the patient requires desmopressin. At the same time, I'll also sought for opinion from nephrology team so that I can manage the patient better. So with this, I conclude the lecture on hypernatremia, and I thank you all for attending this lecture. Let me know if you guys have any questions, and thank you as always.